Welcome my friends, my brothers and my colleagues from the medicine career. Welcome to this your channel, Clinical Consultant. This time I have the pleasure of talking to you about lung abscess. In the previous video we talked about prerectal abscess. I invite you to like the video, and subscribe to the channel so that you can continue watching my videos that I will be uploading. Without more to say, we can continue. Now, I have a question for you to make the video a little more dynamic. If we could remove each of the blood vessels from the body and put them together end to end, how much would that structure measure? Leave your answer in the comments before it appears in the video, to see if you get it right. As a concept we have that a lung abscess is an infection of the lung parenchyma. This infection causes a chronic cavity that later fills with pus. As we see in the images below, we look at 3 images with different contrasts. And we see image 3 much clearer, and we notice that the concept is fulfilled there, which is a chronic cavity. In epidemiology and demography, we know that in the last 30 years, thanks to the advance in antibiotics, the incidence has been decreasing as well as the deaths from this abscess. It is important to say that in patients more than 50 years of age, a lung abscess is generally associated with a primary lung neoplasm in more than 30% of all cases. It must be said that lung abscess almost always coexist with empyema, and that the people with more risk factors are people with alcohol problems, epileptic patients, cerebrovascular disorders with dysphagia, people with drug addiction, people with dysphagia problems, such as scleroderma, esophageal carcinoma, and others. People with poor oral hygiene, malignant obstructive pulmonary disease, and people with bronchiectasis. Between the symptoms and signs, it is important to say that the symptoms are insidious and too prolonged and appear for weeks or months, and among these are fever, chills and sweating, cough, sputum production, purulent and smelly. Some people do not know what sputum is. Sputum is the same as saying phlegm. Chest pain of the pleuritic bone type on the tip of the side. Hematemesis. Dyspnea. Malaise, fatigue, weakness, tachycardia and tachypnea. Dullness to percussion, whispering, pectoraliquia and bronchophonia. Etiology. In etiology we know that the most predisposing factor for the formation of a lung abscess is aspiration. After aspiration, another very important predisposing factor is periodontal disease. Lung abscesses are rare in people at edentula, that is, when we say edentula it is the same as saying that they lack teeth. In approximately 90% of cases they are due to anaerobic germs such as Bacteroides fragilis, Streptococcus, and Streptococcus microaerophils. In most cases, anaerobic infection is accompanied by other aerobic and facultative anaerobic microorganisms, such as Staphylococcus aureus, Escherichia coli, Klebsiella pneumoniae and Pseudomonas aeruginosus. In addition to these bacteria, parasites could also be the Etiology such as Paragonemus westermani and Entamoeba histolytica. Also some fungi such as Aspergillus, Christacticus, Histoplasma, Blastomyces, and Coccidioides. In immunosuppressed patients, in addition to opportunistic infections could be Aspergillus, Mycobacteria, Nocardia and Rhodococcus equi. Diagnosis. First, it must be said that lung abscess can be primary and secondary. We say that lung abscesses are primary when the infection arises from normal infections of the host. For example, in aspiration and pneumonia. The secondary pulmonary abscesses are those that originate because of a basic disorder, as they are endocarditis, lung cancer, pulmonary embolism. In addition, lung abscess can also be classified as acute and chronic depending on the duration of the disease and the symptoms. We say it is an acute lung abscess when the symptoms last less than 4 to 6 weeks. And we say that it is chronic when the symptoms of the disease last for more than 6 weeks. Differential diagnosis. The differential diagnosis is similar to cavitated lung lesions. It is necessary to differentiate the lung abscess from bacterial infections such as anaerobes, infected bulla, empyema, actinomycosis and tuberculosis. Also fungal infections such as histoplasmosis, coccidiomycosis, blastomycosis, aspergillosis, cryptococcus. Also parasitic infections such as ambiosis and chinococcosis. Malignant tumors such as primary lung carcinoma, pulmonary metastasis, lymphoma, Hodgkin's disease, also Wegener's granulomatosis, sarcoidosis, endocarditis and septic pulmonary embolism. Assessment. Before doing any other procedures, it must be determined whether the cause of the lung abscess is primary or secondary. It is important to say that hematological studies are nonspecific for the diagnosis of a lung abscess. Most of the diagnoses are made with radiological techniques. However, in order to reach the precise diagnosis, the specific etiological diagnosis must be made. We need to know the causative microorganism through microbiological techniques. The laboratory tests that we must do, we have to understand this. We must do a complete blood count with leukocytes and perform bacteriological studies such as 1. Do the gram techniques and do sputum cultures. The downside of this is that the samples are generally contaminated by the oral mucosa. So we resorted to the following techniques. 2. Percutaneous transtracheal aspiration. 3. Percutaneous transthoracic aspiration. 4. Fiber-optic bronchoscopy with brushing or bronchial lavage is the most widely used technique to obtain bacteriological studies. Only occasionally are blood cultures positive. It is important that if the existence of empyema is found, germs can be isolated attaining fluid through thoracentesis. In diagnostic imaging, the chest X-ray will lead us to the diagnosis of lung abscess by showing us a cavitated lesion with air fluid levels. Pulmonary abscesses are generally found in the posterior segment of the right upper lobe of the lung. Chest computed tomography can locate and measure the lesion and helps distinguish lung abscess from other lesions such as infected empyema tumors, and so on. Okay, now we are going to answer the question we asked you at the beginning. If we could take out each of the blood vessels in the human body and put them together point by point, how much would it measure? And the answer is yes, my friend, the answer is approximately 100,000 kilometers. In other words, we would rotate the Earth 2.5 times with that extension of blood vessels. In the treatment, I left 3 occupiers in this box. Non-pharmacological treatment, acute treatment and chronic treatment. In non-pharmacological treatment we have techniques such as oxygen therapy, postural drainage, and intensive therapy maneuvers. In acute treatment we can give penicillin 1 to 2 million units intravenously every 4 hours, until improvements are achieved. In other words, we have the patient without fever and with a substantial decrease in sputum production. Then 500 mg VK penicillin is given every 6 hours for the next 2 to 3 weeks, although cycles of 6 to 8 weeks of treatment are generally needed, but this will depend on the response to treatment. 2. Tranitazole with penicillin is administered in doses of 7.5 mg per kilogram intravenously every 6 hours, followed by 500 mg orally every 12 or 8 hours as appropriate. Finally, clindamycin is an alternative option if there is some bacterial resistance to penicillin. The doses are 600 mg intravenously every 8 hours until improvement is seen, followed by 300 mg orally every 6 hours. And in chronic treatment we can say that bronchoscopy can help us with drainage and diagnosis in patients who do not respond to antibiotics or suspected of suffering from a basic malignant tumor. Important to indicate that the surgery is indicated in few cases, in less than 10% in patients with complications of lung abscess. In the forecast, it is important to detail the following. More than 95% of patients recover with antibiotic therapy. Complications of lung abscesses are empyema, massive hematosis, pneumothorax, and bronchopulmonary fistula. Mortality is low if the abscess was acquired in that community, being only 2.5%. But if it was acquired in the hospital, the mortality increases to 65%, this due to the fact that multi-resistant bacteria abound in hospitals. Derivation. In the presence of a lung abscess, the most indicated is to refer the patient to a pulmonologist and to a specialty of infectiology. It is important to say that some important complications of lung abscess are empyema, bronchopulmonary fistula, hepatobronchial fistula, brain abscess. I have the topic of brain abscess on my channel. I will leave you the link in the description so that you can see it. And bronchiectasis. Refractory cases, that is, those cases in which the infection is repeated or caused by different causes such as 1. Large cavity greater than 6 centimeters. Repetitive aspiration. Thick-walled cavity. Base lung carcinoma. Formation of empyema. It is important to say that necrotizing pneumonia is similar to abscess. But the difference is that it is smaller than 2 centimeters and that there are several points of abscess scattered in the lung. Thank you very much for watching the video. I invite you to subscribe and like the video. Next video will be Etiology. Regards.